In the past, evaluating the dental patient for suitability to receive dental treatment used occurs with a single simple question: are you generally in good health? Today, we assess the patient's suitability for dental treatment with a protocol that we refer to as physical evaluation. The purpose of this presentation is to describe the systematic approach to physically evaluate the dental patient prior to receiving dental treatment. This patient presented to the dental clinic with a small yellowish nodule in the posterior soft palate. Upon thorough history taking, you discover this patient has a positive history of pulmonary tuberculosis. What you see here is an uncommon presentation of an intraoral manifestation of tuberculosis. Another patient presents with a history of chronic discoid lupus erythematosus. If a physical evaluation is performed on this patient prior to treatment, precautions can be taken to minimize exposure to light, which can precipitate further episodes of the skin lesions of chronic discoid lupus erythematosus. There are many reasons why we need to physically evaluate the dental patient prior to initializing treatment. These reasons include: many of them are medically compromised, the increased use of medications known as polypharmacy, and the use of inhalation and IV sedation. The major objectives of physical evaluation are establishing the diagnosis, determining pre-existing conditions, discovering concomitant disorders, managing emergencies, and patient management. Remember that establishing the diagnosis is 99% meticulous systematic history taking and only 1% flashes of brilliance. In determining a pre-existing medical condition, do not hesitate to consult a physician when necessary. By having a more thorough knowledge of a patient's medical history, you will be able to design a better treatment plan and manage the patient more effectively. By performing a thorough physical evaluation, you may be able to discover the existence of more than one disease in the same patient, such as hypertension, diabetes, or allergic reactions. We should also be aware of the genetic significance for the development of various conditions such as diabetes mellitus, hypertension, myocardial infarction, allergies, asthma, bleeding disorders, and malignancies. By performing a physical evaluation prior to the treatment, you may be able to prevent most office emergencies. A physical evaluation also informs the dentist of pre-existing conditions. In addition, you should always have a medical emergency kit available, which contains medications such as nitroglycerin and epinephrine. Finally, physical evaluation allows you to better manage your patient by reducing stress and establish a rapport with your patient. The diagnosis and treatment protocol includes the following: thorough medical history, clinical examination of the lesion, differential diagnosis, biopsy or culture if necessary, laboratory investigations if necessary, final diagnosis, establishing a treatment plan, and treatment. Ultimately, a sound and proper patient assessment, complete history taking, thorough examination, and radiographic and lab tests will lead to a final diagnosis. The physical evaluation of the dental patient consists of the following components: history taking, taking vital signs, examination, clinical and laboratory investigations, consultation if needed, and ASA classification. A thorough history includes chief complaint, present illness, past history, review of system, family history, and personal and social history. The chief complaint consists of a description of the patient's problem in his or her own words. The present illness describes the duration of the patient's current chief complaint. A description of the present illness should include onset, intervening period, and current status. The past history includes past medical and dental histories, along with past medication history. Symptoms can be characterized in the following way: onset, duration, frequency, location, nature, severity, course, influencing factors, and associated manifestations. The medical history consists of listing of previously known and established medical facts. The family history refers to genetic or familiar patterns of disease. The personal and social history includes habits such as smoking and alcohol consumption. The review of systems should be systematic, thorough, and should include the following: cardiovascular system, respiratory system, gastrointestinal tract, hematological system, psychiatric, muscular system, genitourinary tract, endocrine system, and neurological system. Other conditions that should be noted include angina, myocardial infarction, rheumatic fever, heart murmur, the presence of a prosthetic heart valve, mitral valve prolapse with or without regurgitation, joint replacement, cerebrovascular accident, and pregnancy. Some of these conditions, including mitral valve prolapse with regurgitation, prosthetic heart valve, and artificial joint replacements, require pre-medication in accordance with the American Heart Association guidelines. The taking of vital signs include recording blood pressure, pulse rate, regularity of the heartbeat, respiration rate, and temperature. A normal blood pressure is defined as being in the range of 120/80. The pulse rate should be in the range of 72 beats per minute. A normal respiratory rate is in the range of 16 per minute. Normal temperature is about 37 degrees Celsius or 98.6 degrees Fahrenheit. The techniques utilized in the examinations of soft and hard tissues include inspection or visualization noting color, symmetry, body development, nutrition, and speech. Palpation or touching noting consistency and mobility in the neck region. Percussion, which is the transmission of sound via structures, is utilized in the examination of the chest and teeth. Auscultation or differential sound transmission is used in the recording of blood pressure, examination of the TMJ, and recording of pulse. Patient health status classification. ASA1, patients with no systemic disease should be able to run 2 minutes or longer and climb 2 flights of stairs without experiencing shortness of breath or any discomfort. In addition, diastolic blood pressure should be less than 90. ASA2, patients with mild systemic disease should be able to walk 2 city blocks at a fast pace or climb 2 flights of stairs without experiencing shortness of breath or any discomfort. Their diastolic blood pressure should be within the range of 90 to 104. Other patients in this category would include well-controlled non-insulin dependent diabetics, well-controlled hypertension, and patients with controlled asthma or allergies. ASA2 also includes healthy individuals with extreme fear of dental treatment and patients older than 65 years of age. ASA3, patients with severe systemic diseases. Patients in this category should be able to walk at a regular pace, but they have limited physical activity. They would be unable to climb 2 flights of stairs without experiencing shortness of breath or discomfort. Other patients in this category include insulin-dependent diabetics, COPD patients, those with a history of angina pectoris, patients undergoing anticoagulant or prolonged steroid therapy, and patients with a diastolic blood pressure in the range of 105 to 114. ASA4, patients with incapacitating or life-threatening diseases. These patients would be unable to do light activity, even for a short period of time, experiencing discomfort while at rest. Other patients in this classification include uncontrolled diabetics, those with unstable angina, patients that have had an acute MI or CBA within the last 6 months, those undergoing renal dialysis, hemophiliacs, and patients with a diastolic blood pressure greater than 115. Now that we have completed the history taking and recording of vital signs, we are ready to proceed with the clinical examination of the patient. This includes a thorough extraoral and intraoral examination. The extraoral examination consists of a general appraisal of the patients, including health, nutrition and temperament, fingernail bed examination, examination of the hair, sinuses, eyes, ears, nose, TMJ, skin, salivary glands, lymph nodes, and neck. The intraoral examination includes evaluation of the lip, labial and buccal mucosa, palate, tongue, floor of the mouth, teeth, periodontium, and the nasal and oropharynx. The basic techniques of examination include visual inspection for the examination of the skin, hair, eyes, and soft tissue of the mouth, diascopy, blanching to differentiate between vascular lesions and other conditions such as amalgam tattoo, palpation, to examine the texture and consistency of lymph nodes and other soft tissues using bidigital and bimanual examination, probing, to determine attachment loss, percussion for the examination of sinuses and evaluation of periapical and periodontal infections, auscultation for TMJ evaluation and identifying jaw fracture lines, aspiration for the examination of intraosseous lesions, evaluation of functions used in the Schirmer tear test, evaluation of salivary flow in patients who have facial paralysis, tests for lack of furrowing in the forehead upon looking upward. Finally, clinical and laboratory investigations. A clinical investigation includes taking radiographs. A laboratory investigation includes microbiological cultures, histological smears, serology, and biopsy. Consultation with the patient's primary care physician should be considered in the following situations. If the patient has elevated blood pressure, is on anticoagulant medications, is indicated for an AHA premedication protocol, has a history of psychiatric disorders and may require sedation, is classified as an ASA3, or has a medical condition with symptoms that are not well controlled. Implications of health status for dental treatment include ASA1, routine dental treatment with no modifications, ASA2, short appointments using sedatives or antibiotics, premedication, and possible modification of treatment, ASA3, consultation if necessary with modification of treatment, ASA4, only emergency dental treatment is indicated, and a hospital setting may be required, or defer treatment until the patient's condition improves to ASA3. Physical evaluation, head and neck examination. The head and neck physical examination consists of an extraoral examination and intraoral examination. Extraoral examination. There are 3 markers that will give us clues about the general health condition of the patient. They are the fingernails, eyes, and tongue. We will take a close look at each of these separately during the examination. The extraoral examination will start with an examination of the fingernails and the skin. Fingernail examination. First, ask the patient to extend his or her hand. The fingernail consists of 3 components: matrix, semilunar configuration at the base of the nail, called the lunula, and the cuticle. The lunula should be clear and whitish. Look for quality and structure of the matrix and observe any pitting or grooving that may exist. For example, a patient with hypothyroidism may exhibit pitting and grooving in the matrix. The color should be pinkish or rosy when pushed at the base. Press from below. If color is cyanotic or bluish, it could be a sign of insufficient amount of oxygenation in the blood. That could indicate, without specificity, a cardiovascular or respiratory disease. If the finger is yellowish in color, this would tell you that there is a hypersecretion of bilirubin. This is an indication of liver disease. Also, look for the angle at which the nail meets the cuticle. Angulation should be about 160 degrees. If greater than that, it could create spooning or clubbing. Both of these are indications of certain diseases. Remember that the fingernail takes about 6 months to grow from the base to the tip, or 0.1 millimeters per day. If there is any problem during this time, it will be manifested in the nail. These are white lines that are called Bose lines. If you notice any of these lines, be sure to ask your patient if any trauma or medical conditions have occurred during the last 6 months. Skin and hair. The next step will be an examination of the skin. Why should we examine the skin? Because some medical conditions manifest themselves on the skin and inside the mouth. For example, lichen planus can manifest itself as violaceous colored circular areas with white lines running through, also known as Wickham's stria. Another disease which manifests itself both intra and extraorally is pemphigus. It can occur on the arms in the form of a bulla. A bulla is a swelling that contains fluid on the inside. If the skin is rubbed, this will precipitate the formation of another vesicle or bulla. This is referred to as a positive Nikolsky sign. Another condition is erythema multiforme, which may manifest itself on the hand as target or bullseye lesions. Watch for any change in color or texture of the skin. You should examine the hand and also the face. We will start with the hand. Begin with flexor and extensor surfaces of the hand and wrist. Look for changes of color which could indicate liver problems such as jaundice. Now the examination of the skin of the face. Watch for any abnormal change of color or texture of the skin. Look for any ulcerations, especially in the middle third of the face. This is a common place for basal cell carcinoma. Look for any pigmented lesions. If you find any, ask the patient when and for how long this lesion has existed. Ask your patient if they have darkened in color or increased in size. Remember that when examining a pigmented lesion, such as a mole or benign melanocytic nevus, to keep in mind the A, B, C, and Ds of melanoma. Any lesion which is asymmetrical, has a poorly defined border, demonstrates color variation with ranges of color from brown, black, white, red, or blue, and has a diameter greater than 6 millimeters, about the size of a pencil eraser, should be referred to an oral and maxillofacial surgeon or a dermatologist for further evaluation to rule out melanoma. Next, examine hair. Fingernails, skin, and hair have one thing in common. All are ectodermal derivatives. If you see any problems here, there may be problems with other items derived from the ectodermal structure, such as enamel. Look for normal quantity and structure of hair. If the hair is sparse and fine, it may indicate hereditary ectodermal dysplasia. This is a problem that affects people genetically. It may also manifest itself in alopecia, or absence of hair. Eyes. Next, we will examine the eyes. Look for color of conjunctiva and sclera. Look for any evidence of ulceration. Ask the patient to look up and avert the lower eyelid. Look for any deviation from normal color, which should be pinkish or rosy. This indicates normal oxygenation and normal intake of iron. If the color is pale, it could indicate deficiency of iron. Now let us examine the upper eyelid. We have the patient look downward and avert the upper eyelid. Examine the sclera for any bluish or other color discoloration. Ask the patient to look up, down, and sideways. Yellow or bluish sclera could indicate problems. Bluish sclera could be an indication of osteogenesis imperfecta, while yellowish sclera could result from jaundice, which would be indicative of such liver diseases as hepatitis. Also look for any grayish, white, or yellow deposits encircling the iris. This could be an indication of hyperlipidemia, high lipid contents in the blood. Watch also for any ulceration that may exist in the conjunctiva. This could indicate that the patient may have such conditions as Stevens-Johnson syndrome, Behçet syndrome, or cicatricial pemphigoid, which also manifest themselves intraorally as well as genitally. Nose. The best position to examine the nose is from the back. Ask the patient to slide back. Look straight and make sure that the nasal septum is right in the center. Any deviation could indicate a breathing problem. Watch the breathing. If the patient must use both the nose and the mouth to breathe, This could produce dry mouth. Plaque will start to build up around the teeth and cause periodontal disease and dental caries. Sinuses. Examination of the sinuses, frontal, ethmoid, and maxillary sinuses. To examine sinuses, use the percussion technique. Place one finger on frontal sinus and tap. Be sure to repeat this on the sinus on the other side of the face. On the maxillary sinus, place finger and tap. Again, repeat the same thing on the other side. Ask the patient if there was any discomfort during the sinus exam tapping. If the patient experienced no pain during the examination, this indicates that there is no problem with the sinuses. In other words, there is no sinusitis. You can also confirm this by looking at the panoramic image. If you see no indication of cloudiness, that will confirm your finding. TMJ, joint of the jaw. Examination of the TMJ using auscultation. Place your stethoscope about 1 inch from the tragus. Ask the patient to open the mouth slowly and all of the way. Ask the patient to close slowly. Ask the patient to open quickly and close quickly. That is one of the best methods to examine the TMJ for clicking or popping. To examine any jaw deviation, watch the patient from the back. Ask the patient to open and close and watch for deviation to the right or left. Another technique of examining the TMJ is palpation. Use fingers to feel for any sound during the opening or closing, just like with a stethoscope. Ask the patient to open and close slowly. You should be able to hear any popping or crepitation of the TMJ. Ear. During examination of the ear, be sure to move hair out of the way so that you can have a full view of the ear. The ear consists of an auricle, a helix, external auditory meatus, tragus, and an antitragus. Look for any evidence of laceration or ulceration of both ears. Also, look to the back of both ears for any evidence of problems, in other words, lesions of actinic keratosis or squamous cell carcinoma. Lymph nodes, salivary glands. To examine the lymph node system, you will examine the submental lymph node, submandibular lymph node, preauricular lymph node, postauricular lymph node, occipital nodes, and the cervical nodes. First, we are going to examine the submental lymph node. The best way to examine the submental lymph node is to first bring the patient into an upright position. Then ask the patient to relax. This will allow you to move their head freely. We will use the palpation technique. Use 2 fingers for the submental examination. Ask the patient to tilt head forward. Roll skin against the border of the mandible and try to palpate the lymph nodes. You may not always feel them, but try. Then, with 4 fingers, examine the submandibular lymph node. Tilt patient's head towards you and always roll against the mandibular inferior border. Next, examine the preauricular lymph node to see if there is any lymphadenopathy. Then, examine the postauricular lymph node. Remember that the survival rate for oral cancer that extends into this region and goes unchecked for 5 years or more is less than 37%. Neck. Here we are going to look for any swelling that affects the thyroid and tonsils. At the end of the extraoral examination, be sure to remove your gloves. First, remove one, turning it inside out. Then removing the other, turning it inside out also. Fold together and place in the trash. Put on a new pair of gloves for the intraoral examination. Intraoral examination. Lips and labial mucosa. The first step of the intraoral examination is at the lip and labial mucosa. During the examination of the lip, look closely at the vermilion border as you move intraorally. Watch for any evidence of cracking, scaling, chipping, or fissuring. Also look for any evidence of a poorly defined vermilion zone or any leukoplakic lesions which may indicate the presence of actinic cheilitis. Then, reflect the lower lip to show the labial mucosa and examine for any evidence of ulceration, irritation, or inflammation. You should be able to make determination if the patient has dryness of the mouth by wiping out the saliva and waiting for 1 minute to see if pearls of saliva come out from the minor labial salivary gland. If it takes more than 1 minute, that is an indication that the patient may have a problem with dry mouth. Buccal mucosa, cheek. To examine the buccal mucosa properly, we must stretch it out. However, you must be very careful not to overly irritate the patient's tissues, especially in a patient over 65 years of age. In the older patient, both the labial and buccal mucosa become thin and atrophic. Ask the patient to open to see if there is any evidence of irritation or white lesions forming. That is an indication of Fordyce's granules, which are ectopic sebaceous glands. We will examine the labial mucosa and buccal mucosa by using bidigital examination, using 2 fingers from 1 hand. Floor of the mouth. To examine the floor of the mouth, use a bimanual examination technique by using 1 finger from each hand and holding the tissue between them. Look for any swelling in the salivary glands, presence of sialolith formation, or any submandibular nodes. Palate. Examine the palate for evidence of tori. Gingiva. Look for evidence of recession, excessive bleeding, or any surface submucosal lesions. Maxilla and mandible. These are both examined using a bidigital approach using 2 digits of 1 hand. Feel for any evidence of bony expansion, which would signify the presence of an interosseous lesion. Salivary gland. The parotid glands can be examined by palpation, and the submandibular glands can be examined by using bimanual technique. Also check for salivary flow from Stenson's and Wharton's ducts. Tongue. Hold the tip of the tongue and look at the very back at the base to check for any evidence of ulceration or white lesions. Be sure to check the lateral border of the tongue on both sides. Remember that 50% of all squamous cell carcinomas occur at the lateral border of the tongue. Then ask the patient to touch the tip of the tongue to the roof of the mouth and examine the floor of the mouth. This is all part of oral cancer screening. Tonsils. Look for the presence of the tonsils. If present, note their size, color, and if there is any evidence of purulent exudate. Oropharynx. Have the patient say, "ah," and examine the oropharynx for a normal pink color and for any lesions. Note that the oropharynx is normally redder than the rest of the oral cavity.